This is Dr. Daniels, Level 4, lecturing about chest trauma and pleural drainage. We're also going to be talking about abdominal trauma. Okay, so chest trauma, caused by some mechanism of injury. It can either be blunt or penetrating. A blunt injury is when the chest is struck with something, typically with like an object like a bat, or if it was in a car accident, it's struck by the steering wheel. There's typically some kind of deceleration, acceleration, shearing, or compression. A lot of times on the outside, there's very little damage, so the external, there's minor, but internally there can be severe damage. The damage can be on the same side as the impact, or it could be on the opposite side. And this can be life-threatening, such as if the aorta is torn or an organ is ruptured. With penetrating injuries, there's an open wound, and the severity of the wound depends on the location of the wound and if any organs were involved. This is what we talk about. Penetrating wounds are like when a foreign body gets impaled into the body tissue, or a knife or gunshot wound. So a pneumothorax, what is it? It's when air enters the pleural cavity. And this causes positive pressure in the cavity, which causes the lung to collapse. So normally what you see, right, this is that little kind of blue line that you see around. This pink is all the lung, and then this is like the pleural space, which you can't really see in this picture. And there's a negative pressure, and that negative pressure holds the lung open. When you get any kind of air that enters the pleural space, it causes the lung to collapse because there's positive pressure. It's positively pressing the lungs because air is entering it. And it can be opened or closed, which we're going to talk about right now. So an open is where air enters through an opening in the chest wall, or like the outer lining. So right in here is where it enters. So this is an open wound. So like your knife wound that we talk about. Right there. A closed is where it's actually the inner lining of the pleural is disrupted. So we're talking about along here. So air comes from the lung itself and escapes into the pleural cavity. There's no external wound. So like we said right there. Right there. So how do we diagnose it? Chest x-ray is the best way to diagnose it. You'll see the presence of air or fluid in the pleural space. You'll see a reduction in the lung volume. And clinical manifestations are variable. Most notably, you're going to have some dyspnea, right? Anywhere from some mild dyspnea to some severe respiratory distress. They might complain of chest pain, cough, might have bloody sputum. They'll get tachycardic because they're having to work really hard, they're in pain. And they're going to have absent breath sounds over the affected area, because think about it. You have, this is the lung, this is where you're exchanging air. You're not going to hear any air being exchanged over this space. So those are those absent breath sounds. So there's different types of pneumothorax. So now we're going to talk about the different types. The first one is spontaneous. And this is where there is a rupture of small blebs or air-filled blisters located at the apex of the lung. There's primary, which is in healthy young individuals, and secondary, which is lung disease. So this would be a type of closed pneumothorax. It's where these little blebs rupture that are sitting on the lung and they release air into that pleural cavity. Some risk factors are smoking, tall, thin, male, and oftentimes have a family history or have had a previous spontaneous pneumo. These are very classic. When you see these kids come in, they'll be tall, skinny, like 18-year-old boys, 16, 17, 18-year-old boys. And they come in and they say they were, just hanging out and all of a sudden got chest pain and started having trouble breathing and their heart was racing. And we'll do a chest x-ray and they have a spontaneous pneumothorax. There's no history of trauma or anything else. All right, another type of spontaneous pneumothorax is when we actually lacerate or puncture the lung during a medical procedure, such as like a subclavian catheter insert. You can have a traumatic penetrating or traumatic blunt. Again, penetrating is like what we talk about with a stab wound. And oftentimes we talk about this sucking chest wound. Oh, sorry, that was my dog. So with a sucking chest wound, air is entering during inspiration. So how do we treat this? Let's think about this. If you have your, I'm going to get, your lung space right here. And you have a hole right here. Every time you breathe in, air is getting into that space. So you breathe in and you're pulling air out. Or pulling air in, I'm sorry. And then when you breathe out, you push that air back out. So you breathe in and out, in and out. And you're pushing that air in and out. So it's that sucking chest wound. So we want, as the more air comes in, the thinner that lung's going to get, right? Because more air is filling that pleural space. And now you have this little bit of area for lung. You don't have as much lung anymore. So what we want to do is cover that with an occlusive dressing that's secure, but we only want to secure it on 3 sides. 1, 2, like 3. We want to leave a flap open because we want every time for them to, as they breathe in, we want that dressing to kind of collapse against the skin. But when they breathe out, we want that dressing to open up, to let air out. So it's really important that if we have any kind of traumatic, penetrating wound, that we cover it with that occlusive dressing that's secured on 3 sides, or a vent dressing, so that air cannot enter during inspiration, but that we can kind of blow the air out during expiration. Okay, let me get rid of that. So then next we have, and it's important not to remove the object. So if the knife is stuck in the, the chest still or anything, or, penetrating foreign body, do not remove the object. You stabilize it with a bulky dressing, and you still do the 3-way vented dressing. Other traumatic is blunt. Again, that's like if you get hit with a bat or the steering wheel. It can be close when it can happen, like a rib that's fractured cuts the lung and allows air to leak out into the pleural space. All right. A tension pneumothorax. So these can be kind of scary, and they can be caused by all the different types we've talked about. By an open pneumothorax, a closed pneumothorax. It can be closed by CPR. It can be closed by clamping a chest tube, which we're going to talk about in just a second. And what happens is that air will enter the pleural space but can't escape. That's why we do, when we talk about penetrating wound, that's why we do the vented dressing, the three-way dressing, so that trapped air can get out. But when you can't get that trapped air out, a tension pneumothorax occurs. With that, the mediastinum, so right here, this kind of midline, it gets shift to the unaffected side, right? So you have all this pressure that's pushing, because all this negative air, it's pushing against the midline and pushing it against the unaffected side. Because of that, the good lung gets compressed. So you already have a lung that's deflated, and now your good lung's getting, right here, your good lung's getting all smushed, and your O2 is going down. It also causes pressure on the heart, right? Because your heart's sitting right here. So you've got pressure on the heart and on the great vessels. So if you've got pressure, you're also compressing blood vessels. So it's decreasing the amount of blood that can come back to the heart. And we just sat here and talked about all of this in our cardiac test. It decreases the cardiac output. So they become hemodynamically unstable fast. So they have decreased O2. They're not stable because we're compressing the vessels, compressing the heart. We can't get blood back to the heart. Cardiac output's dropping. These patients, it's a medical emergency. So what are they going to present with? Obviously, they're going to be having dyspnea. They're going to have a really hard time breathing. Increased heart rate and the tracheal deviation. So you'll see right here, the trachea will deviate to the unaffected side. Now, I guess they have it more here, but no breath sounds on the affected side because, again, you see right here, there's no lung there. This is the lung. This is all just open pleural space, so you're not going to hear any breath sounds over that. They can get JVD, jugular vein distension, cyanosis. They can be diaphoretic. They're anxious, right? Because think about it. Their cardiac output's low. They're not feeling well. They're having a hard time breathing. Treatment, they need immediate needle decompression. So normally this is when I would show you a video. You can YouTube it to see, but needle decompression is the treatment of choice. And basically they go down over the rib and insert a needle into the pleural cavity space and let all that air out immediately. Like I said, I highly recommend you Google it or YouTube it. There's tons of videos that show procedures, show it get done. But when you stick the needle into the pleural cavity, you'll hear this whoosh of air. And then typically you'll stabilize the needle until you can get a chest tube inserted. All right. So as we continue on with different types of pneumothorax, there's also a hemopneumothorax, and that's just instead of air in the pleural cavity, there's blood, and that's typically because of injury. We treat that with also a chest tube, and if there's a large amount of blood, we go ahead and reinfuse their collected blood. You can have a hemopneumothorax, which is both a hemothorax with a pneumothorax, so both blood and air in the space. And you can have a chylothorax, which is lymph fluid in the pleural space. And the drainage you'll see is a milky white drainage. And it's often treated by keeping fat out of the diet. So you can have just air coming out, you can have serosanguinous fluid coming out, you can have milky drainage coming out. What you shouldn't have is pus. That would indicate an infection. So what are we going to do for treatment? Well, that depends on the severity. Some pneumothoraxes are very tiny. Others, and the tiny ones may resolve spontaneously. You won't have to do any treatment. Others are more severe. like your tension pneumothorax. And those are going to require a thoracentesis, maybe to aspirate, or even a placement of a chest tube. Now, with a drainage system. So a chest tube with a drainage system is the most definitive and common form of treatment. You can do a pleurodesis, a pleurectomy, where they actually go in and like remove. This is very good for spontaneous pneumothorax. So they go in and they remove the blebs or remove part of the lung that's causing the issue. And again, needle decompression. And those are used for tension pneumo during a medical emergency. And they're often followed by a CT. All right, so what are chest tubes and drainage systems? Hopefully we're going to get to talk to you a little bit more during the roundabout and show you in person. But chest tubes help remove air and fluid. Typically, we're going to chest tubes placed at the top of the rib cage help remove air, and chest tubes placed more near the bottom of the pleural space remove fluid, blood. They basically reestablish that negative pressure. Again, you have these lungs, right? And they're kept open because you have this negative pressure pulling them open. Everything's kind of pulling it out. What happens when the lung collapses is when you have positive pressure, so the lung collapses because you have positive pressure because air is in that pleural space and it's pressing down and compressing the lung. So what the chest tube does is goes in there and takes that out, because kind of sucks it back out so you can recreate that negative pressure. Take away our little drawings. So they're about 20 inches long, 12 to 40 French. And when they insert it, they put the head of the bed up. It's aseptic. They'll suture it in place and put that occlusive dressing. And confirm placement with chest x-ray. And good pain control is needed because these patients do hurt. They're not comfortable. Having a tube stuck in your chest, especially, think about it, if it's like a 40 French, oh my gosh, you definitely need to control pain. Okay, so here's the different types of chest tubes. This one is called a water suction. All right, and it's important to understand the difference. This right here is the collection chamber, okay? And it spills, so it will fill up, fill up, fill up. All these three sections are the collection chamber. That receives fluid and air from the pleural space. The water seal chamber right here, which is, it's C on this diagram. So D is the collection chamber, C is the water seal chamber. And the purpose of the water seal, it always holds about 2 centimeters of water, always. And it acts as a one-way valve. So it allows air to basically come in and go through the collection chamber and escape out, but it doesn't allow air back in. So think of it kind of like you're swimming in a pool and you put your head underwater and you blow a bubble. You can blow a bubble and it will go up to the surface of the pool and escape, but you can't push that bubble back down underwater to you. So it allows that air and the fluid to get out, but the water seal makes sure that air can't go back into the system. So it's a one-way valve. So air from the pleural space and collection chamber can escape, and water prevents the backflow of air to the patient. So what we don't want to see and hear is bubbling, because bubbling is bad. That means there's an air leak. Now, there is one exception. When you first put in a chest tube, when they are putting it in because there's a giant pneumothorax, you're going to see a bunch of bubbling because there's going to be a bunch of air that's being released when you first insert it. But once the initial air has been released, there should be no bubbling in this water seal chamber. If there's bubbling in this water seal chamber, then we know that there's some kind of air leak. Tidling, which is fluctuation where the water moves gently up and down, that's good. That basically, it's like us breathing. You know, when our chest expands and goes back down, you're going to see the same kind of fluctuation in that. That's fine. The last chamber, which is right here, A, this right here, this is the water-filled suction control chamber. So basically, this is what's keeping the negative pressure. It's filled to 20 centimeters of H2O. And you are okay to have bubbling here in this chamber right here. It applies suction to the chest drainage system. So that's what's going to keep your negative pressure. So you've got your D chamber collecting any fluid or air. You have your C chamber, which is keeping that water seal, not allowing air to go back into the patient. And then you have A, which is your water suction, so water filled up to the 20 centimeter line. And bubbling is okay there because it's either going to be open to air, it will not be bubbling, or it will be to suction, and you'll like low continuous wall suction, and you'll see a gentle bubbling. So that's okay in A, but never in C, except for when you first insert. All right, the difference between a water seal and what this is, which is a dry seal, is you still have the collection chamber. So you still have this collection chamber. Functions the same. You still have the water seal chamber right here in C. Functions the same. 2 centimeters of water acts as a water seal. But the difference is, instead of having, like before, that tube on the left-hand side that you could see the water, here they just have a dial, and that's dry suction. So there's no water. You dial in the desired negative pressure. So again, this is still in control of keeping the lung open by putting that negative pressure. There's just no water doing it. And you have to vent it when you're decreasing the pressure. All right, so how are we going to take care of it as nurses? Well, one, when we're ready to put in a chest tube, we've got to prepare the unit. We have to add water if it's a water seal. We need to maintain patency. It's really important that when we go in, we make sure that all connections are taped, that the tube is taped to the patient's chest wall, that the tube coming out of the patient, the chest tube, is taped well to the collection chamber tubing. And that tubing is very long, so we have to make sure that it's loosely coiled and not kinked. We want to observe for tidling, the fluctuation up and down, and bubbling, which we don't want in that water seal chamber. We need to assess the clinical status, like vital signs, blood pressure, this is breath sounds, breath sounds, pain. The drainage amount. It's really important that if a patient is draining more than 100 mLs an hour, that we report, because they are at risk for developing a hypovolemic shock, whether it's due from a loss of large amount of fluids, or they might be bleeding in their cavity. So if they're putting out more than 100 cc's an hour, that is significant and needs to be reported. We need to look for any drainage site infection. Like we talked about, there should be no pus, redness, drainage from around the wound. And any subacute emphysema. And I'm going to talk about that in just a second. We want to encourage them to use their incentive spirometer and good range of motion. We want to help them, turn and cough and take deep breaths to keep those lungs open. Do not milk or strip the tubing, and do not clamp. So the reason we don't do that is because of the tension pneumothorax. Whenever we kind of clamp down or milk it, milking means to kind of like squeeze the tubing and pull it, that's going to cause that pressure to increase within the lung cavity. So we want to keep a negative pressure, right? We're trying to pull that lung open. So if we clamp down, what we're doing is then putting a positive pressure on the lung and allowing it to collapse and possibly causing a tension pneumothorax. We don't want to elevate the system above the chest because you're going to have fluid draining back into the lung cavity, pleural space. And we don't empty it. When the collection chamber is full, we change out the whole entire unit. It's not like a Foley that you empty or anything like that. So what are some complications? So you can get re-expansion of pulmonary edema or a vasovagal response. So if too much fluid is removed too rapidly, they can get symptomatic hypotension. We talked about subacute emphysema. This is where air leaks into the tissue surrounding the chest tube insertion site. It feels basically like Rice Krispies underneath the skin. You'll palpate the skin and it just crackles and pops right underneath your fingers. A small amount is totally okay. Sometimes we see, a little air leak out into that space and it doesn't bother the patient. We just continue to monitor. But if it is a large amount, we have to be careful because too much air in the subacute space can cause swelling around the neck and can compromise the airway. We worry about infection, always do sterile technique with dressing changes, and follow hospital protocol. We put the occlusive dressing on it with the date and time. Emergent care. So what happens if you're taking care of your patient and transport comes to pick them up or the tech's there or even you, we overturn and disrupt the water seal. So remember that water seal is so important because it helps make sure that air doesn't go back to the patient. So as soon as we notice that it's tipped over, we want to return it to the upright position. Then we're going to have the patient take a few deep breaths followed by a forced exhale and cough. We're trying to reopen that lung and recreate that negative pressure. And by forcing exhale and coughing, we're allowing any air that may have gotten in to be pushed out. If the chest tube itself becomes disconnected, so the tube is connected to the patient and the tube on one end and on the other end is connected to the chest tube device. So if the chest tube from the patient becomes disconnected from the device, we want to take the end that's connected to the patient and stick it in 2 centimeters of sterile water. Again, that's going to basically act as your water seal so that air can't get in. Because again, think of it like swimming in a pool. You can blow a bubble to the surface, like if you're underwater, but you can't push that bubble back underneath. When we remove a chest tube, when the lung is re-expanded and there's minimal drainage. So typically what they'll do, they'll put a chest tube in and have it to suction. And they drain a bunch out, they get a bunch of air out, they get a bunch of fluid out. Then the patient kind of stabilizes, there's not as much drainage, they're doing well, vital signs are stable, breath sounds are clear, they've got good O2. So they turn it off suction and keep it to gravity, meaning that the chest tube is still in, but it's not actively sucking. And if the patient still does well, then they consider taking it out. So suction deseed, water seal for at least 24 hours. We pre-medicate. Again, this is painful. We have them Valsalva bear down during the removal so that we don't allow any air into the cavity. And we immediately apply the occlusive dressing. So we're going to go ahead and get all our materials ready. We use a Vaseline gauze. So we'll have a dry gauze, Vaseline gauze on top of it, tape ready to go. And as soon as they pull the chest tube, your hand is there to just occlude the hole with the Vaseline dressing and then put the tape over it. We're going to monitor for any respiratory distress, get a chest x-ray, and if they show any signs of respiratory distress, they might need to get the chest tube put back in. All right, rib fractures. Rib fractures, most common is ribs 5 through 9, and it can damage the pleural and the lungs. Clinical manifestations, pain, obviously, splinting, shallow respirations, atelectasis, pneumonia. And how do we treat? We used to strap or bind the chest because we thought that that would help put that pressure and decrease the pain. But that actually made atelectasis and pneumonia worse because we weren't getting the full chest expansion. We do use good pain medicines, NSAIDs, opiates, even nerve blocks if we need to. We want to encourage them to deep breathe and cough and use an incentive spirometer. So flail chest, what is it? It is a fracture of several consecutive ribs in 2 or more separate places. So it's an unstable segment. So you can see right there, you have fracture, 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 fracture. So this piece right here is completely independent of anything else. So what we have is this paradoxal movement during breathing. That means like when the affected area moves in the opposite direction than the intact portion. So during inspiration, the infected portion is sucked in. So normally you take a breath in, your chest goes out because your lungs are expanding. But when you have a flailed chest, the part that's, broken off actually gets sucked in instead of being pushed out. And during expiration, when we breathe out, we're kind of pulling all the air, our lung is collapsing, everything should kind of pull in. But because we're pushing out, the effective portion bulges out. So it's paradoxic movement, moves opposite of normal. So obviously we're not going to have good ventilation on the affected side. They're going to have to work way harder to breathe. And it's very apparent on physical exam. You'll oftentimes see this during any kind of blunt trauma, like if they get hit with a bat or hit the steering wheel. They get rapid shallow breathing, increased heart rate, crepitus. So diagnostics, obviously we can either palpate it or we can visualize those paradoxal abnormal respiratory movements. We get a chest x-ray, ABGs, and treatment. Remember, ABCs, so airway management is very important. We need to put them on a ventilator or supply oxygen if needed. IV fluids, pain control, and surgical fixation. They may even require some CPAP or BiPAP. So with chest trauma, what's our nursing assessment? Respiratory distress. Do they have any dyspnea? Do they have any cough? Cyanosis? Any tracheal deviation? Decreased breath sounds? Decreased O2? Frothy or bloody secretions? And because of things like the tension pneumothorax, is there any cardiac compromise? Do they have a rapid thready pulse? Is the blood pressure gone down? Do they have any JVD? Any muffled heart sounds? Chest pain? Dysrhythmias? So anytime there's chest trauma, we got to make sure not only are the lungs okay, but the heart also. And what is some intervention on our part? We've talked about this. Always ABCs, so patent airway. We want to breathing, keep the O2 above 90%. IV access, remove clothing to see what the injury is. Cover a sucking wound because we don't want any more air coming into that pleural cavity. The more air in the pleural cavity, the more positive pressure, the more collapsed your lung is going to become. We want to instabilize impaled objects. Do not remove them. Semi-Fowler's position. Needle decompression or potential intubation. And monitor things like vital signs, level of consciousness, oxygen, heart rate, respiratory rate, urine output. All right, so that pretty much covers chest trauma. We're going to briefly talk about other types of trauma. Abdominal trauma. Organs, we can either hit solid organs, like your liver, your spleen, which could cause profuse bleeding and hypovolemic shock, or we can hit hollow organs, like your intestines, where contents can spill in the peritoneal cavity, causing a peritonitis, which is an infection of the belly, basically. So what clinical manifestations are we going to see? Obviously pain, guarding, splinting, decreased bowel sounds. We can hear bowel sounds in the chest. They might have a rigid or hard abdomen. They might be throwing up blood. They may get abdominal compartment syndrome, and this is kind of a scary thing where they have decreased respiratory rate and decreased cardiac output. Because of this, there's so much pressure inside the abdomen that it's pressing up against the diaphragm, the lungs, and the heart. Gray Turner sign is what you see right here, this kind of bluish discoloration. It's around the belly button. You can also see it right here. That's Gray Turner sign. I'm sorry, that's Cullen sign. Gray Turner sign is bruising on the flanks. So that would be on the sides, and I don't have a picture of that. So bruising on the flanks is Gray Turner sign. Cullen sign, I apologize, is the bruising around the belly. Both of these pictures represent Cullen sign. And that's blue discoloration around the belly. Those are both indicative that there might be some kind of internal bleeding. Abdominal trauma, continued diagnostics, CT, X-ray, ultrasound. You can do a peritoneal lavage. I have worked in the ER for a long time, and I don't ever see these anymore, just because CT is so non-invasive and effective and quick. But with the peritoneal lavage, they take, a liter of fluid and they actually insert it into the peritoneal cavity. And if they get less than 10 mLs, then they consider it a negative. But if they get, and they lavage with the 1,000 liters of normal saline, and then they send it off to the lab. But if they get more than 10 mLs, that it's considered positive, and they're going to prepare for surgery. But like I said, you rarely see this anymore just because CT has become so efficient and effective. So how are we going to treat for abdominal? Again, always ABCs, patent airway, fluids. We may need to do decompress the belly with an NG tube. Put a Foley in. Again, leave impaled objects in place. No pain meds until we confirm a medical diagnosis. We don't want to mask anything. Prepare for emergency surgery and prevent or assess for sepsis, especially if we hit like a hollow organ like the intestines and we have bowel that's spilled out into the abdomen. All right, pelvic trauma, fractured pelvis. It's easily missed and is associated with high mortality. Oftentimes the mortality is related to severe intra-abdominal injuries or paralytic ileus, maybe hemorrhage, a laceration of the urethra. Clinical manifestations, swelling in the area, tenderness, bruising, deformity, unusual movement. In treatment, we want to assess. There are special mattresses that they can use. We want to minimize complications like a DVT. pulmonary embolism, sepsis. We want to get them up, get them moving, get their lungs expanded, get the blood going, control their pain, and help with any urinary and bowel function. Last is limb trauma, and this is gonna zip through just because you guys had this in level 3. You assess neurovascular, the 6 P's, pain, pallor, paresthesis, immobilize the area, and we're just going to be careful about compartment syndrome. If needed, we can treat with a fasciotomy like what you see here. All right, that is the nitty-gritty for chest, abdominal, pelvic, limb trauma. And hopefully, like I said, we'll get to get more in depth with the chest tubes. Not more in depth, but get more hands-on, I should say, with the chest tubes during the roundabout. Thanks and have a good night.